Say it.
Asthma. For my nature.
Oh dear.
Asthma.
Asthma is a chronic inflammatory disorder of the airways that is characterized by bronchoconstriction or bronchospasm, airway edema, bronchial hyperresponsiveness, airway inflammation, and airway obstruction. On the left, we have a normal bronchiole, which has a nice relaxed bronchial smooth muscle and a nice dilated airway, allowing for good airflow in and out. And then on the right, we have my bronchiole, which is constricted with tons of inflammation and a buildup of airway secretions, causing really poor airflow. So usually during an asthma attack, the airway is exposed to a specific allergen or irritant. The allergen activates the IgE antibody response. The antibodies attach to mast cells and become antigen receptors. When more of the antigen enters the airway, it binds to the IgE antibody receptors, causing the mast cell to undergo degranulation. During degranulation, the mast cell releases its contents, which include histamine, cytokines, and other mediators. These substances cause the bronchial smooth muscle to constrict, the airway to become inflamed, and the mucus to accumulate inside of the airways, all of which contribute to the overall airway obstruction seen in an asthma attack. Bronchial hyperresponsiveness is exaggerated bronchoconstriction in response to allergens and irritants. The extent of an asthmatic's hyperresponsiveness directly affects the degree of airway constriction, inflammation, and mucus accumulation. So I like this picture because it breaks everything down. It shows the allergen exposure here. It shows the plasma cell producing the IgE antibodies against the allergen, which then attach to the mast cell here. When more of the allergen enters the body, it attaches to the antibody receptors, which cause the degranulation of the mast cell and the release of the histamines and other mediators. This picture again is just showing the anatomy of an asthma attack. Like shown before, this is a nice dilated airway, nice airflow in and out, while this is an obstructed airway due to excess mucus, inflammation, swelling, and smooth muscle constriction. Here are the alveoli, and while an asthmatic can force the air in, it is hard for them to get the air out due to this bronchoconstriction, which causes them to purse-lip breathe or try to create a back pressure to get some of the trapped air out. There are two classifications of asthma. Extrinsic asthma, also known as allergic or atopic asthma, occurs due to exposure to certain antigens. Bronchospasms are antigen-antibody induced. There's an anaphylactic hypersensitivity reaction. It is genetically related. Onset usually occurs in childhood or before the age of 30, and it can lessen or clear up after puberty. Intrinsic asthma, or non-allergic or non-atopic asthma, on the other hand, is not linked to antigen response or extrinsic factors. It's only classified as intrinsic if tests cannot identify any allergen reactions for the patient. It usually appears after the age of 40, and although it is not linked to a specific antigen response, intrinsic asthma is still considered to be activated by IgE synthesis. So the most common asthma-inducing factors, mainly for extrinsic asthma, would be pollen, dust mites, cockroaches, mold, pet hair, dander, changes in weather, respiratory infections, smoke, stress, physical activity, allergic reactions, heartburn, acid reflux, or GERD, certain medications, and genes or heredity. Some susceptibility. You are 6 times more likely to develop asthma if one or both of your parents have it. It is estimated that 20% of asthma sufferers are children, and that number is higher amongst boys. After puberty, females are actually more susceptible to developing asthma. Asthma is most prevalent among African Americans, and the elderly often succumb to asthma or asthma-related illness more often than any other age group. Anatomic alterations of the lungs, bronchoconstriction or bronchospasm, bronchial inflammation, the excessive thick white secretions from the allergy response, mucus plugging, alveolar hyperinflation, also known as air trapping, and atelectasis due to the airway obstruction. Here are the common symptoms during an asthma attack. The shortness of breath and tightness in the chest are due to the overall airway obstruction from bronchoconstriction, inflammation, and airway edema. The wheezing sound is due to the air passing through the narrowed and inflamed bronchiole. The thick white sputum was produced during the IgE allergen response and the release of the histamines. And then that will create a cough because that's the body's natural way of trying to expel the excess secretions in the airway. The accessory muscle use can be seen in patients who are having to work harder to ventilate past the airway obstruction, as well as the pursed lip breathing, trying to create a back pressure to release some of the trapped air. The cyanosis and hypoxemia will eventually occur due to improper ventilation and oxygenation. These are the common tests and procedures used to either diagnose asthma or show the severity of an asthma attack. Spirometry is used to measure the lung volumes and flows. So normal values for the forced expiratory volume in 1 second or peak expiratory flow should be greater than 80%. However, someone with moderate asthma will have an FEV1 or PEF of between 60 and 80% of the predicted value, which would show an obstructive lung disease like asthma. Allergy testing can be done either by skin or blood serum, and it will measure the body's response to the asthma-inducing allergens that cause the attacks. The peak flow can be used to measure the person's ability to breathe out, which shows the severity of bronchoconstriction during an attack. The values are dependent on the patient's height. During the patient assessment, you might hear diminished breath sounds with inspiratory and or expiratory wheezes, possible rhonchi from airway secretions, and in some cases even crackles due to atelectasis. The respiratory rate would be increased due to the hypoxemia. The patient is not ventilating and or oxygenating well enough. The sputum would be white and thick due to the allergic response. The cough is productive and often worse at night. The patient's position, usually sitting upright, tripoding, they could be on all fours. Their appearance would be cyanotic, pursed-lipped breathing, increased work of breathing, accessory muscle use, anxious and agitated. The chest x-ray would show hyperresonance, increased rib spacing, flattened hemidiaphragm, hyperaeration, and atelectasis. The ABG would show respiratory acidosis with hypoxemia. The labs would show increased eosinophils and basophils, and the test would be positive allergy skin test, IgE antibodies and serum, decreased PFT, and peak flow values. Asthma is diagnosed through history, examination, symptoms, pulmonary function tests, and allergy testing. So currently there is no cure for asthma, and there are 180,000 annual deaths worldwide. Although asthma cannot always be prevented due to environmental and genetic factors, it can be controlled with daily maintenance medications, proper medical care, allergen avoidance, and healthy lifestyle choices. So, hospital treatments for a standard asthma attack would include oxygen therapy, usually a 2-liter nasal cannula or higher, depending on the severity of the attack, nebulized treatments, short-acting beta-2 agonists like albuterol, or anticholinergics like ipratropium bromide. Corticosteroids like solumedrol are given to reduce airway inflammation, and bronchial hygiene therapy like PEP or suctioning would be used to expel the excessive airway secretions. This table shows the common asthma drug therapies. For an acute asthma attack, you would want to use a reliever like a short-acting beta-2 agonist like albuterol, or an anticholinergic like ipratropium bromide. Long-acting beta-2 agonists are known as controllers. They help to prevent acute exacerbations of asthma. Those will be your formoterols and your salmeterol. Other preventers are inhaled corticosteroids like beclomethasone and budesonide, as well as your leukotriene receptor antagonist like Singulair. There are also combinations of the controllers and corticosteroids, like your Advair discus, which is fluticasone and salmeterol, or your Symbicort, which is budesonide and formoterol. While most asthma attacks can be treated with conventional therapies, there are certain instances that would cause a need for intensive care, like status asthmaticus, which is a severe acute exacerbation of asthma that does not respond to standard treatments of bronchodilators and steroids. The symptoms include chest tightness, rapidly progressive dyspnea, dry cough, use of accessory respiratory muscles, labored breathing, extreme wheezing, mental status depression, and hemodynamic instability. It's a life-threatening episode of airway obstruction and considered a medical emergency. Complications can include cardiac and/or respiratory arrest. Respiratory failure or severe respiratory acidosis with high levels of CO2 and extremely low levels of O2 would also be a cause for intensive care, along with any comorbidities associated with asthma like ARDS and/or lung infections like pneumonia, which would prevent asthma from easily being treated or cleared up. Discharge plan for asthmatics would be to avoid known allergens or irritants, a daily regimen of antihistamines, i.e. Claritin, short-acting beta-2 agonist for an acute exacerbation, long-acting inhaled beta-2 agonist to prevent exacerbations, inhaled corticosteroids to prevent inflammation, a peak flow meter to assess lung function, to create an asthma action plan that will help to assess the need to seek medical intervention, smoking cessation, and asthma education.